Okay, I am going to go ahead and get started as people trickle in. So I brought this paper today. It's a relatively recent one out of JVIM, primarily because I think it's a pretty cool differential, but also just to switch it up a little bit and talk a little bit more about the lower urinary tract and some of the interventional stuff that we can do. And so this is study title, Placement of an Artificial Urethral Sphincter in 8 male dogs with urethral diverticulum. And we'll get right into it. So as far as the introduction goes, they obviously present what a UD or urethral diverticulum is primarily in human medicine, and it seems to be pretty vague. So it's variable presentations of urethral disease, but namely things like cyst dilations, and then pouches of variable sizes in various locations throughout the urethra. They then go into talk about just incontinence in males in general, which, as we all know, is quite uncommon, with ectopic ureters and USMI being reported a little bit more frequently. We did and are working on a retrospective out of NC State that showed of these incontinence males, about half of them do have some sort of disorder of storage. The other half disorders of voiding. And then they talk about the artificial urethral sphincters, which is, again, kind of what I want to be the main discussion point of this. And these artificial urethral sphincters are currently used for cases of refractory urethral sphincter mechanism incompetence, or USMI, right now, with the goal of the implant being like a true partial mechanical obstruction. So to kind of limit that flow. And then they've mentioned various minor and major complications previously, minor usually being those that are self-resolving or respond to medical therapies, and then major being ones that usually involve the implant that require some sort of surgical fix or interventional fix, as well as some of these kind of more specific AUS-related problems like the fibrous bands or capsules that we'll talk about later. And so this was a multi-institutional retrospective done over about 14 years. And as the title suggests, it just included these male dogs with UD that were treated with an artificial urethral sphincter and had at least 1 month post-op follow-up, most of them much more than that. In this study, they defined a urethral diverticulum as a congenital or acquired outpouching that is in continuity with the urethra, and then further go on to describe them as either saccular or diffuse, where they're at in the urethra, and then whether they were suspected to be congenital or acquired. They did collect the info that you would expect about the artificial sphincters, so timing of placement, the size of the sphincter itself, complications, inflations, the volume that they used, and then they further defined any sort of minor or major complications with the device as those that were either medically treated or required surgical revision, respectively. They did assess the response to this placement too, mostly by means of continence scores, so UCS. This is the scoring system that they use, which has been used before. I can't see how many people are on. Does anyone want to volunteer if they use a similar continence scoring system? I ask because I know there's at least one other paper that uses like a 1 through 9 scoring system. I think I'm used to using the 1 through 5 or 0 through 4. Does anyone have opinions or experience there?
We've started using the scoring for some of our recent dogs, but it's not something we've been tracking very consistently until very recently.
Okay, the 1 through 5.
Yeah. Mm-hmm.
Okay. Because I got used to, like, especially during residency fellowship, we would send owners home with like a continence scoring system to determine kind of the partial responders. And yeah, I was always used to this 5-point, but I didn't know if people were using larger scales. So, and briefly about the artificial urethral sphincters, like kind of more from a surgical standpoint, which I had to refresh myself on. This is taken from a study that we'll talk more about later out of JSAP from 2022. But the sphincter placement itself, it's generally done with the dog in dorsal recumbency. They create these 2 incisions, the caudal abdominal, to access the urethra and the bladder, and then usually a paraprepucial or umbilical skin incision for the port itself. What they'll do is they'll retract the bladder and then kind of pull it out and dissect the urethra caudal to the prostate. They put the occluder around, or they put it caudal to the prostate around the urethra, secured in with suture, like you see here. The yellow star is the urethra. And then again, they place that port in the umbilical region. Most of the surgeons that I've talked to about this do what was described here, in which they will inject saline into the cuff until they can palpate noticeable resistance from the cuff, but then they'll completely deflate it, but just kind of take note of how much saline they infused to get that noticeable resistance. But a large majority, or I think all of the ones that I've been exposed to, they close the surgery with there being no saline or no fluid in the device itself. And so in this study, again, 8 dogs, 5 were intact, 3 were neutered, various breeds, with an 11-month median age, a pretty large range there as well. A median age of placement being about 2 years, also a pretty large range, and all had urinary continence scores of 1 out of 5, which is the least continence, all but 1. And then most of these dogs were incontinent since birth, so a congenital origin was suspected, and 7 out of 8. And then 1, interestingly, they believe to have occurred after they corrected bilateral ectopic ureters. So the ureteroseals were extending into the urethra, and the urethral diverticulum later developed at that site where they transected the ureteroseals. They did importantly note a lot of what concurrent anomalies they could find. Before they get into the more congenital ones, they did mention that 5 out of 8 of these dogs did have UTIs, all of which were treated, none of which had improvement in their continence scores with treatment. And then various of these other congenital abnormalities or presumed congenital abnormalities, there was 4 of them that had ultrasound changes that were consistent with either renal dysplasia or chronic pyelo, like the differences we'll usually get with a kidney that looks like this when they're young. 3 of them were bilaterally cryptorchid, and 3 of them also had pelvic bladders. There was 1 with a persistent urachus, 1 with an ectopic UVJ that was, I think, on the ventral bladder surface, and then 1 also did have a urethral colic fistula as well. All of these dogs were trialed on medical therapy before they had the occluder placed. All of them did receive PPA at appropriate doses for a median of 6 months. A little over half of them did have some degree of improvement, but it was either just mild to moderate or transient. And then 2 of these cases also received 2 different formulations of testosterone. However, neither of these guys had improvement. 2 of them also had urethral bulking procedures performed either in the proximal urethra or proximal to the os penis, which similarly resulted in mild temporary improvement. I did want to ask too, so I know this has been on the listserv before. Do we have any other experience in the group with urethral bulking in males?
I've done collagen in 1 male dog that didn't have ectopics, just USMI.
Where did you do it?
We did a perineal approach, and we did it in the prostatic urethra.
Okay.
It's been, I don't know, 2 or 3 months, and he's still dry. So
cool.
Seems to be doing okay.
Nice. We had tried it once during my residency, actually for one that ended up getting an occluder, and we did it in the distal urethra through a rigid scope, and then we talked about doing it perineal. I don't know if they've done it there since, but seems like relatively limited experience with that in males, but I was just curious.
I think JD had one that he did in the penile urethra that did not last very long.
Yeah, we didn't get it. We found it because at least in the dog that we did, the urethra was so narrow. There wasn't a whole lot of even with the flexible scope, you really couldn't get a good angle to direct the needle submucosally, but that was just our experience. Okay, so moving on to their imaging findings, all of these cases did have I should have used a different acronym here, an ultrasound and then some sort of contrast cystourethrogram. Interestingly, 7 out of 8 of these dogs did have normal ultrasounds, but one of them did have a tortuous dilated proximal urethra. That's what resulted in the subsequent CT, which is what diagnosed the urethral diverticulum in that dog. They do further describe the prostate in all of these dogs, which was kind of variable. So one, they didn't see on ultrasound, 2 were difficult to visualize, 2 were normal, and then 3, there was no info, and whether that meant that they didn't see one or they just didn't include it in the report, I don't think they knew. But in all of those other dogs that didn't have a CT, it was a combination of cystoscopy with retrograde positive contrast, either under fluoro or radiography to diagnose the UD. In all of these cases, the diverticula was a localized pouch-like structure, and all were saccular except for one that was bilobed. A large majority were within the prostatic urethra, and then one was in the membranous. So this image on the right, the X, as you can see, is the bladder. The star is the urethral diverticulum. These are just some cool images, which I think, so this shows the bilobed one. And so obviously very marked dilation at these 2 different places, 1 and 2 that you can see on scope and on the imaging. I think most of us would have picked up on this being abnormal here, but I do wonder, and there's an image later of a contrast study where the dilation is focal, so not bilobed, and it's a little bit more mild. And I wonder in some of these dogs that we scope, like we expect some degree of dilation in the prostatic urethra. So I wonder how much would look different if we see contrast studies, but we can talk about that. So for the surgery itself, all of them were done by boarded surgeons. And again, they go on to talk about the prostate a little bit more. It was normal in a little less than half, but hypoplastic in 3 and not visualized in 1. My numbers are not correct here because it was also not mentioned in 1 too. But one of the hypoplastic prostates did have these like white nodules that they, I don't think knew where they were coming from. In 6 out of 8 of these cases, the artificial urethral sphincter was placed distal to the UD in the distal third of the prostatic urethra. For that bilobed one that we just showed a second ago, they put the sphincter between the lobes, and then they put the sphincter between the trigone and prostate for the UD that was in the membranous urethra. This is an intra-op image, obviously, so X is the bladder, and then kind of cool here, you can see the star is actually the dilated prostate or dilated urethra. For the surgery itself, no reported complications. Most of them were, the median amount of hospitalization was about 2 days. And then, like we talked about before, all of the cups were empty or deflated at discharge. So complications moving forward, again, no intra or really perioperative complications, and the complication rate overall was fairly minimal. There was 2 dogs that had what they described as minor complications. Both of them presented with straining and some degree of overflow incontinence, but both were fixed simply by deflating the cuff. The major complication was one that occurred almost 5 years after placement. It sounded like he was straining for about 6 months, and they probably troubleshot it for a bit, initially partially deflating, but ultimately diagnosed an obstruction via contrast study. And then they found one of these fibrous capsules, cultured staph sued out of it, and then removing the sphincter and the capsule was curative. This is an image from a paper we'll talk about in a second that shows here bladder, urethra, and then this like fibrous capsule that they had to transect. And so this is just a little bit more info about these capsules that are associated with the urethral sphincter devices. I haven't seen one yet. This is a study out of DACVIM from 2022 that talks about 6 cases that did develop it. Only one of these cases was male. But it sounds like these capsules can develop pretty long after placement of the device. So a median of 884 days after placement before they presented with symptoms from the capsule. It sounds like all of these dogs were, again, a little bit older, the symptoms that you would expect, but they found that stenosis via some degree of urethrooscopy or some combination of urethrooscopy and contrast studies, and then found that fibrous capsule associated with all of them. It sounds like the transection, similar to the case in this study, transection of it did result in resolution, but interestingly, all of them did have positive bacterial cultures, and it doesn't sound like any of these cases had recurred after they dealt with the capsule themselves. Does anyone in this group has anyone seen these? Okay, I'll take that as a no. Okay, so back to our study in terms of follow-up and outcomes. Most were alive by the end of the study. 2 were euthanized for unrelated reasons, so reasons unrelated to the incontinence. Interestingly, both of those dogs, though, did develop diseases or were on medications that caused PUPD that did result in a subsequent worsened urinary incontinence score. So all of these dogs with UDs with the sphincters placed did have improvement in their continence score, with a median of 4 out of 5, again, with 5 being completely continent. 6 out of 8 of them just had improved and 2 completely resolved. Of the dogs that resolved, it sounds like 1, they found the right amount of saline and it was good long-term. The other 1 did require regular inflations to maintain a UCS of 5 out of 5. All but 1 required inflation post-surgery. So it sounds like 1, they never had to put saline back in. The first inflation occurred anywhere from 22 to 100 days with a median of 40 days, median amount of follow-up visits being about 4, and then the median total volume of saline being 1.2 mils. And I think I have it on the next, or in a slide later. They did use saline as opposed to something like high-visc, which I will talk about later too. And so moving into the discussion, just kind of the general discussion, obviously the veterinary data on urethral diverticulum is quite sparse. This does represent the largest number of dogs that it was described in. For the 2 that were previously reported, they treated it surgically, so with a surgical diverticulectomy. And both of those cases did improve. They did remark, though, that because it was longer hospitalization following those procedures when compared to the artificial urethral sphincter placement. But it sounds like surgery is probably the more common intervention in humans for this issue, with various numbers of surgical techniques, but really none of them seem that great or curative, and many end in what's called penile clamps, which I was too afraid to search. The dogs in this study, they remarked that they weren't fully classified as storage versus voiding. They did note from the history in 2 that they had a weak stream, so postulated that maybe those were 2 that had a disorder of voiding, but post-voiding residual volumes weren't measured for any of them. In contrast to humans, it does seem like a congenital cause is more common in dogs, at least in this study, with 7 out of 8 being congenital. I think interestingly, for humans, placement of an artificial urethral sphincter actually is reported to cause urethral diverticulum in humans because of those changes in pressure. Obviously not evaluated in this study, but I don't think it's been reported in dogs. UTIs are also common in humans, and we saw that in this study, and they presume that's due to just urine stasis. But it sounds like UTIs after surgery are pretty common in humans, and they do seem to happen in dogs as well. Of note, a little under half later present for straining to urinate. 1 was because of a major complication with that fibrous capsule. 2 was just because the cuff was too inflated, but it's a pretty large range as to when this can happen. And so I did just want to talk too about these artificial urethral sphincters in male dogs with just standard USMI. They do have a full paragraph about this in the discussion, citing that JSAP paper that I mentioned earlier. So for these dogs that have been looked at before, or at least reported before, with just standard USMI that have an artificial sphincter placed, a large majority of them do pretty well, or at least improve in some way, with 13 out of 19 becoming fully continent. That number does drop in terms of persistent incontinence. So beyond 12 months, it sounds like, at least in that study, only 8 out of 15 remained continent long-term. But that is in contrast to only 2 dogs that were continent or completely continent long-term in this study. And so I think fairly unsurprisingly, we get a poorer response in these dogs with a true anatomic cause compared to USMI. But again, this is the study that they talked about earlier, and that I think is at least worth mentioning, that looks at 19 cases of male dogs with USMI. And basically, it seems like a pretty good option for those dogs that are refractory to medical treatment. But probably one of the biggest takeaways is that the complication rate was over half, with actually a fairly even split between minor and major complications. And so this just kind of goes over all of the different cases. It's similarly a fairly wide mix of breeds. Most of the dogs were fairly young. A lot of them had been on at least one type of medical therapy prior. And again, you can see here that at less than 12 months, a lot of them were fully continent. That change is greater than 12 months. And most of them did require inflation. In this case, again, one of the bigger takeaways is just that complications were fairly common. And so of the over half of these cases, especially excluding the ones that were lost to follow-up, did have some type of complication, with half of them being major. Again, the major ones generally requiring surgical intervention. But what I also wanted to talk about, just for my own knowledge and to see what the group does, is they do talk a little bit more about the inflation schedule and kind of what they did in these cases. And so for most of these dogs, they started doing inflation 7 to 10 days post-placement of the sphincter. And in this case series, they did successive inflation or injections of 0.2 mils of saline every other day until continence was achieved or strange area developed. And when one of those things developed, they would remove 0.1 milliliters. I haven't had a lot of experience with these guys in the last year being out in private practice, but we had at least one male and then a fair number of females during my fellowship and residency. And we always kind of, it was always, we never quite standardized how we wanted to address inflations, especially for the more difficult ones that seem to have a little bit trickier, a little bit smaller changes in volumes that resulted in continence. And upon kind of looking into this a little bit further, there is this study that shows that as far as the amount of fluid that's required to achieve continence, basically the correlation between that volume and the degree of continence or pressure in the urethral sphincter was nonlinear and had pretty considerable individual variation. And so they found that even very, very small amounts of changes in fluids can result in pretty significant changes in pressure. And so they suggest quite smaller increments of filling, so 0.05 to 0.1 milliliters, which I feel like we have seen. Also, because of this very small volume that seems to create a big difference in some dogs, we kind of stopped using high visc for a lot of these cases because it's so viscous, it's difficult to create such small or adjust such small volumes. And I wanted to get the group's take to how much are you adjusting these when you're adjusting them? And are most people using saline, or are they using another fluid? Anyone have any input? Okay, well, yeah, like I said, we were just using saline, and I probably won't go back to high visc because it was pretty annoying. So they discussed the concurrent abnormalities too, which I think is pretty important. So it does seem like these concurrent urogenital abnormalities are common. There was enough cryptorchids that they postulated some degree of a correlation between UDs and cryptorchidism. And then also talked about prostatic aplasia because this has been previously reported in the other dogs that have had urethral diverticulum. And in this case, or in this study, the prostate was at least hypoplastic in 3 out of 8 and not visualized, possibly absent in 1. So that's half of the cases having small or absent prostates. So one of the takeaways is they do recommend thorough evaluation for concurrent urogenital abnormalities. I thought this was interesting too. So it sounds like some people are even placing these laparoscopically. I asked my surgeons here, none of them had done it. I do wonder if this, and this may just be my lack of understanding of laparoscopy for this case in general, but I think because of the commonality of concurrent congenital abnormalities, I can't help but wonder if doing it laparoscopically would at all minimize your ability to find those. I'm not sure it matters from like a therapeutic standpoint, but just something that kind of came to mind when I was thinking of doing this laparoscopically, but it's cool that some people can do that for sure. And the diagnosis, which is probably the biggest takeaway to me. So in humans, some combination of advanced diagnostics or advanced imaging is required. So in humans, they mentioned all of these things listed. But in humans, they often can palpate the urethral diverticulum, which doesn't seem to be the case for dogs, which would make sense if most of these are prostatic. But at least in this study and in concurrence with humans, multiple versions of imaging are required. So usually cystoscopy plus contrast imaging. And then this was the case that I was talking about earlier. So again, they used a combination in 7 out of 8 cases. I can't help but wonder, like, so based off of this contrast study, and the star is where the UD is, like, I guess I'm curious what that would actually look like on cystoscopy, because again, we expect to see some sort of dilation there. And I wonder how many times I've just kind of sped past that, assuming that it was normal and maybe there was a mild UD. But it looks like, but again, they vary. And so some of those are a lot more significant and more obvious on cystoscopy. Recommend ruling out ectopic ureters with that scope. And then in general, it does seem like some degree or some type of contrast study is required for diagnosis. Limitations wise, this was retrospective, so pre-artificial sphincter management was not standardized. There's fairly varied follow-up, and then they did develop the continence scores retrospectively. And so they noted that it was a little bit difficult to differentiate between scores of 3 versus 4, especially when talking to owners that may have either over or underestimated their true continence. But this could all be improved, they say, with a standardized questionnaire or grading scheme. And so I think in general, this is kind of a cool differential to include in cases of male incontinence. But you do have to do advanced diagnostics, maybe more than we usually do. So like including a contrast study with the cystoscopy. Usually I'll just work these guys up with cystoscopy, but I'll probably start adding at least some sort of contrast study. And then they recommend looking for concurrent abnormalities, simply because they're, one, super common, but at least a fair percent of them will have a concurrent abnormality that's probably worth addressing, like cryptorchidism. And then in general, for response, you can expect some degree of improvement. I think the bigger question is how significant and how long that improvement's going to last, but it does seem to be an overall good option for these cases. And that is all that I've got.
Thanks, Tanner. Since you're talking about hydraulic occlusions, can I use this moment to ask if anybody's used them for treating a hypoplastic or put them on a dog with a hypoplastic bladder before? I'm getting the same number of responses that you did, Tanner.
That makes me feel a little bit better. I haven't, but I will do that.
Yeah, I'm a little bit worried it would be one that you'd get complications with, although you could argue that it would make the bladder stretch.
Yeah, it'd be like kind of a veterinary form of bladder training.
Yeah.
Like putting it around the urethra still and in a non-incontinent but hypoplastic bladder?
Right. Because the reason I'm hesitant is because we had one that it was a really bad congenital anomaly, but she developed severe hydronephrosis. So it wasn't that her bladder took on the extra pressure, her ureters took on the extra pressure. And this dog that has the hypoplastic bladder also had ectopic ureters, so she probably doesn't have no, she doesn't have good UVJs. And so I'm just a little bit concerned about go into hydraulic occluder, and I'm not really sure how to do bladder training.
Are you guys still just using saline for inflating them, Dr. Beta?
That's a really good question. We haven't had one recently, but I know that we still have one that we still use hyaluronic acid on, and it is more difficult to use.
Yeah.
It'd be nice to know whether it actually was more effective or not, which I don't get the feeling that it is.
Yeah, it seems to vary pretty significantly. And I thought it was interesting in that one study that some dogs do seem to have a nonlinear change in their pressure despite very small changes in volume that may not affect other dogs, which I think is a little bit validating for some of those more difficult to calibrate cases.
Yeah.
We've had a couple of cases recently that have been quite frustrating, and that how we do use hyaluronic acid here, and how much we've been putting in to the occluder. It's not equal to how much we've been able to get out of the occluder.
Yeah.
And it's like variably variable, which is extra frustrating.
But I think that's true even of saline, is that you can't get everything back, right?
Let's see, our most recent one actually had like 3 years of continence on saline, came back quite recently, did hyaluronic acid, and I was not, I think JD did it, I wasn't here for the second time, but we put in like 0.7 mils and got like 0.2 mils out, and then I don't know, put in like enough to get to 0.8, and then the dog occluded, and then tried to get it back into like 0.75. It's just, occluders can be incredibly frustrating sometimes.
Sure.
Yeah, it seems like you never really know how much volume is going to be in there, which means you never really have like a good target.
Absolutely.
Cool. Well, any other takeaways, thoughts, comments, concerns?
Hi, Tanner. This is Whitney Vickery.
Hey.
I enjoyed your talk. I'm just curious, since you're down the road from me, is this something you're exploring doing with any of your surgeons in the future, or are you referring them at the moment?
For just placement of occluders?
For replacement, yeah.
Yeah, at least 2 out of the 3 of my surgeons are trained, so we'll definitely do
nice.
it if we have the cases.
Okay,
but
awesome.
Yeah, most of the male incontinence dogs I'm seeing lately have been overflow, not something that would benefit from a occluder, unfortunately.
Yeah, same.
And I'm sorry, I had to step away for a little bit, so I may have missed this. I'm not sure like how many people are going like straight for occluders and skipping bulking, or are people like trying bulking first? Obviously, you know, the male dogs are not very common, but I'm kind of curious about that.
For male dogs or just incontinence in
Or just
general?
like incontinence in general.
I think every case that I've been involved with that ended up with an occluder we had tried, even the male that I can think of, we had tried bulking first. But yeah, I didn't ask the group that question. I don't know if people have other thoughts. Is that what you're doing, Steph?
Yeah, we've been, obviously I think like we have a little bit of a skewed perception in that the dogs whose occluders are extremely frustrating are the ones that come back over and over again.
Right.
But even like in the really young animals, we have definitely been reaching for bulking first because it's so much less of a pain in the ass.
Yeah. Yeah, I feel like the usual flow is that I'll recommend it with cystoscopy to rule out anatomic abnormalities, and just since we're in there, go ahead and give it with the understanding that it's probably not going to last, but it'll kind of be a diagnostic, and then we can talk about repeating it or occluder at a later date. But most of these cases do pretty well for a while, or the owners want to repeat bulking.
Yeah, and we also, like, our standard is also pretty much to do fluoroscopy on all of these at this point too. just to look for like intrapelvic bladders or other unexpected abnormalities.
Mhm.
But then it's kind of nice because when they come in for the second time that we book them, it's like 5 minutes in and out.
Yeah. All right, cool. Any other thoughts? Okay, I think we're done, Summer.
All right, thank you, guys.
Thanks, Tanner. Thanks, Summer.
Thank you. Bye.